Today we're going to be talking about the mask impact on effectiveness and adherence to therapies. Full disclosure, this presentation was built by some of my colleagues over at Respironics. I added to it. I do not have any affiliation with them any longer. So today we're going to review the importance of mask selection and fit for adherence. We'll discuss the specific criteria that may impact mask selection, including patient morphology, medical conditions, psychosocial issues, and personal preferences. We're also going to identify how technical features of a mask can contribute to compliance, discuss the importance of patient-driven design and empowerment of adherence, and also explain mask impact as it affects effectiveness and adherence to therapy. So Medicare's definition of adherence to therapy is using a PAP device greater or equal to 4 hours per night for 70% of the time during a 30-day consecutive period within the first 90 days of usage. Medicare also requires that that patient go back no sooner than 31 days, but no later than 91 days to be reevaluated by the physician to make sure that everything is going well with therapy. That changes with RAD devices, but in regards to PAP and BiPAP, those are our coverage criteria. So one of the first things we're going to talk about are how can we predict if somebody's going to be adherent to therapy? And one thing that we've seen in research is that disease severity, age, and prescribed PAP pressures are not necessarily related to if a patient's going to be adherent to therapy. What we did find, though, is that patient demographics, and especially claustrophobia, which some of you can probably attest to that if a patient feels claustrophobic, they're not willing to use their mask. But we did find out that patient demographics also played a small part in whether or not a patient was going to be compliant. We researched inner cities around Chicago, Cleveland, Minneapolis, and Madison to see if a socioeconomic status lowered the impact of adherence, and it did. It was relatively low, but it did impact that. Oh, sorry. Poor PAP adherence at risk. Sorry. Adults with reduced nasal cross-sectional area. So if someone has deviated septum, they're more likely to be non-adherent to PAP therapy. We did discuss claustrophobia. We'll touch a little bit more on that. But then one of my favorite patients when I was working in the clinical setting, the patients that didn't believe in it. Why am I here? You probably have had those patients where there's a spouse that's dragging them into their study or dragging them into the DME to get set up with their PAP device. And it always amazed me that it was always my big men that were always the biggest complainers about whether or not they were going to be successful with this. And then we're also looking at persons who have experienced difficulty with CPAP. Now that might not be personal, but maybe they had a friend or family member that was on therapy and they didn't have a success, or they didn't have success with it. That also contributes to whether or not a patient is possibly going to be adherent. Now, talking about what mask we need to put on a patient or what mask will work for a patient to make sure that they have a high likelihood of being adherent to PAP therapy. Who has their favorite mask that they like to work with in the lab? I was one of them in the DME. I was one of them. Full facers? Anybody? Love them? Indifferent? Okay. There we go. I can fully attest that if I was going to see a patient or do a setup in the patient's home, I was taking a small, medium, and large F20, and I was taking a WISP for the possible nasal mask. And what I'll talk about here today is just keeping that patient in mind. What is going to work for them? and not necessarily what works for us in that short time that we're with them. And Byron and Dave mentioned it here earlier, but we're in the lab, we're with these patients the most amount of time that somebody's probably going to be with them their entire treatment of PAP therapy. So keeping that patient in mind, not necessarily what works for us, what doesn't leak during a study, what's going to cover almost every orifice of their body so that it doesn't leak or they don't start breathing through their mouth. But like I said, keeping that patient in mind. So a few things that will, I feel like talking down, my double chin's hanging out. But a few criteria for selecting the correct patient interface. We're looking at, once again, morphology, conditions and pathology, personal preference, and psychosocial issues. And these are critical areas to look at when we're trying to consider or considering selection of mask interface. And when we're discussing patient morphology, we're looking at variations in facial structure or features. I'm sure everyone can, relates to, you've got that patient that comes in, they have a really large nose or they have a really small nose, they have a large mouth, there's a large gap between their nose and their mouth. I'm sure we've seen them all. But the other is patient medical condition and pathology. What conditions and their circumstances are those patients going through? And that may help us focus on what type of mask to put them on. And once again, psychosocial issues, claustrophobia, self-image, education, and then understanding the importance of why using PAP therapy is detrimental, or not using PAP therapy can be detrimental to their health. And then we've got personal preference. I'd have patients come in all the time that they had a neighbor that had a PAP mask that loved it. It worked great for them. It must work great for me. Anybody else ever run into that? Bingo. So just diving into morphology here a little bit. One of the determining factors of if a mask is going to work for a patient is we're looking at possibly the narrowness of a patient's nares. And do they have have they had a deviated septum? Do they currently have a deviated septum? A patient with a deviated septum, a nasal pillow might not be the correct mask for them just because we're applying all of that pressure right into their nares. I touched on this, but variations in nose structure. I said big nose, but eagle nose we've seen with our patients. And also the symmetry of the face, teeth. Do they have a mustache? Do they have a beard? And then, does the patient suffer from any nose bridge pain or anything along those lines? We're also evaluating the patient's medical conditions and pathology that need to be considered. An evaluation of the patient and their circumstances may help the clinician focus on the specific type of mask that they need to use. Is the patient a mouth breather? Do we know that prior to them starting therapy, or are we making an assumption that when we start them on therapy, they're still breathing through their mouth because they're having apneas, because our pressures are not adequate? And then personal preference, once again, desire for improved visibility. The manufacturers, luckily here, within the last few years, they've taking that crossbar off, like we're a linebacker for the Packers. And now we've got a lot of the masks that are a lot smaller. They're just going over the bridge of the nose or sitting underneath the nose, and then covering that mouth as well with the full face. And does the patient prefer less facial contact, fewer pressure points, or less bulky? Psychosocial issues. When a patient comes to you and they put this mask on for the first time, would you call it life-changing? Could it be life-changing for them? Whether in a good way or bad way. Either we're going to change their life, they're going to feel better, or they have possibly a bed partner that does not necessarily prefer to sleep next to somebody where air is blowing possibly in their face at night. So just psychosocial issues to think about. And also, once again, feeling of claustrophobia and self-image. I always love the mask at ResMed with the For Her line with the pink or blue headgear. It always made patients feel a little bit better. But they're both the same color in the dark. So, fun picture here. So, question, have you ever seen a turtle in a swimming pool? Anybody? What we're getting at here with this slide is the amount of patients that you see on a full face mask should be relatively similar to the amount of times that you've seen a turtle in a swimming pool. Are we overutilizing full face masks because they're easier for us to titrate with, or like I was doing in DME, going to the patient's home, setting them up, and I knew that the mask, they weren't going to breathe through their mouth, that wasn't going to be an issue, nor was I going to have a massive leak. So just evaluate that, think about that. Full face are for some patients, but are we overutilizing that type of mask? The right mask is crucial for PAP success. The selection of the appropriate patient interface is a major consideration when factoring in, is the patient going to be successful? In the early stages of PAP therapy, like Tammy was talking about before, we know if somebody's going to be, we can predict if somebody's going to be compliant within that first week of usage, if they're using it or not. And then also making sure that the mask interface fits properly and meets the needs of the patient is also important in deciding which mask to utilize. Meaningful innovation of the mask can help the patient be more compliant, as it will not be a hindrance to them using their therapy. Anything that helps motivate them to wear their mask. We were just talking about, Tammy was also referencing MyAir and the Dream App or app, any of those apps that we can utilize to drive adherence with therapy. The big thing is, a mask is more than just an interface between the patient and the device. It has the power to engage them and motivate that patient on their journey to a healthy lifestyle. So think about that. The decision that you all make when you put a mask on a patient in a sleep study is possibly going to be the mask that they'll be with throughout their entire therapy. Studies have shown that the mask that we use in the sleep study, that patient sticks with between 60 and 70% of the time. So the impact that you have on their therapy is remarkable. The chances that they're going to switch from what you all put them on is very unlikely. So on the manufacturing side, I would like to say that the manufacturers look at patient-centric designs. They're looking at how easy is it for a patient to use their mask, whether that be magnets, whether that be smaller headgears. How easy is that to get on and off throughout the night? I'm sure noise also plays a factor. Does anybody ever have a patient that complains of the exhalation that's coming out of their mask? I mean, some of the manufacturers now, they've put in place a filter on the exhalation port to help muffle that noise. Obviously, excessive leaks, if we're leaking, Tammy just discussed that in more detail on how leak can actually be adverse to certain types of therapy if the leak level is too high. Cumbersome equipment, today we've gotten away from those, the larger masks like we were discussing earlier with a crossbar on the forehead brace. And then just discomfort and red marks on the face. Another thing that I did want to touch on is technology that makes a difference. Byron was talking about AI earlier. So a lot of programs out here now that are based on AI and mask fitting technology. Has anybody implemented these in their practice? No? Yes? From the back? Okay. So now we have AI to where the patient can either take a selfie on their phone, and the phone will take roughly thousands of measurements to actually fit the patient for what they're considering a correct mask. And really what these technologies are doing is trying to prevent mask refits. On the DME side, mask refit percentages vary from 30 to 40% sometimes, where we put that patient on a mask and it doesn't work. We have to change that out. These technologies that have really come about more so in 2020, when we couldn't necessarily touch patients or visit them in the homes to fit them for their mask, we were utilizing technologies, Sleepglad, Sovasage, or Respironics has their 3D mask selector. Where I see these going here in the future with the AI mask fitting technology, a lot of people that are getting into sleep programs these days, they're wanting to not have contact with the patient, which sounds, it's unbelievable. But it seems like that's where we're going, at least on the CPAP side. RTs and clinicians within a DME, I think they're going to be taking care of more of the higher acuity patients. And these AI technologies are helping us develop remote PAP programs to where patients aren't coming to the office, clinicians aren't going to the home. We're setting that patient up in the comfort of their home on their time. One thing that these softwares have also helped, along with remote PAP setups, is no-shows, no calls, no-shows. We're not running into that patient didn't show up for their appointment. We're setting them up, like I said, in the comfort of their home. Once again, choosing the appropriate mask. The mask should be designed to deliver as normal of a natural experience as possible. I don't know, really, it's not natural what we're doing here, placing patients on CPAP. We're trying to change the patient's lives, but it's not natural. This is new to them. Also, how can we minimize leak? Once again, maximize comfort and improve adherence. With the Philips design and ResMed as well, a lot of their masks now are somewhat interchangeable, where if you start a patient off on a nasal mask, you can build that same mask into a full face by just changing out a few different parts. Characteristics of a lot of the masks that we're seeing here today, they're smaller, they're lighter than they were in the past. A lot of the masks have gone to the top of head tubing. Air flows down the pathway of the frame. Minimal contact underneath the nose, which helps prevent red marks. And also, as I spoke before, the mask is modular. We can turn this into a full face mask if need be. Some of the downsides to traditional full face mask or traditional mask that we were discussing earlier: limited line of sight, restricted movement throughout the night, cumbersome tubing. I always loved when the patient called me and said, hey, my machine fell off my nightstand. I got wrapped up in it last night. It got wrapped around my head 4 times. Whether or not that was a bed partner that was doing that or not, I don't know. Still haven't questioned. But cumbersome tubing prevents that from pulling the machine off the nightstand. And then also broken seals, less effective therapy. I wanted to touch on the hospital side of this for the acute care setting a little bit. Many of you have probably had, who all works in a lab versus is an RT, works on the floor? Any RTs? Okay. Floor work at all? Okay. So what we're trying to do in the hospital side, and other, I should say, manufacturers are trying to do now, is getting that patient on a mask in the hospital side and being able to continue therapy at home with that same mask or a similar mask, similar design cushion. It's one thing that the folks at Philips have worked on and other manufacturers as well. but making it so that it's not completely foreign to them when they get home and they have a similar mask. And what these masks are trying to do, especially in the acute care setting with breakdown of the skin, we're trying to prevent that and other pressure sores on the face. Once again, a lot of the manufacturers out there have masks that can cross the continuum from the acute care side to the home care side. And then just touching on effectiveness and adherence. Having the right mask can help contribute to adherence for PAP therapy, which we touched on earlier. Using patient-driven design helps lead to the right mask and better adherence for patients. The other thing is PAP follow-up programs. So once that patient is actually set up on therapy, so it's important to get them set up on the right mask the first time. But it's also important that we are following up with that patient. Do any of your labs have follow-up programs, like Byron was mentioning here earlier, where you guys are talking to them after they're set up? CPAP clinics you're hosting? Okay. Have you noticed that your compliance percentages have increased since developing or implementing these programs? Okay. We're doing the same thing in the home. A lot of DMEs that are seeing success in their elevated compliance percentages, they're implementing either third-party or trying to incorporate it in-house programs to where that patient's followed up with on a regular cadence. And in turn, we're seeing elevated compliance levels with those patients. I don't know where I'm at on time. Oh boy. Q&A. It's yeah. Right? Oh yeah. So the question was, do I think that any of the manufacturers are looking at making headgear or the apparatus itself? Okay. Our patients. I would say, and just speaking from my days at Philips, working in DME, my pediatric patients, we saw more of that. Especially with the WISP mask, you've got your giraffe headgears for your peds patients. So to speak, that you can get on Amazon and other stores. Will there? I think because when I would approach it as put your mask on. It's time to put your trunk on. And obviously, there's a ton of help that we need from parents as well. Bribing sometimes worked. But putting your trunk on was always even though it was a giraffe, it made no sense. Putting your trunk on a giraffe, so. Yeah. Yeah. Stuck. Right.
So I think all those things, and considering working with patients, I think it helps them become more compliant and know more about what they're doing in their pet therapy and what outcome for them. I just think it's a better thing.
Yeah, I don't say that I was above trying the scare tactics at certain points with patients. I definitely, yeah, Reggie White, being from Illinois, everybody in Northern Illinois knows of Reggie White, up being a Packer, and Reggie White's name was thrown out quite a bit, and the fact that you will die, may not die, but yeah. It definitely does. You catch their attention, and Tammy mentioned earlier, when we're doing a PAP setup, we have roughly 10% of their attention throughout that hour that we're taking to set them up. So whatever can catch. Now, being at BJC there, did you, having to implement this program, did anybody on your team balk at that, thinking that it was more work on their end that the DME should be taking on? That's fair. That's fair. Anything else?
So to Boone on the national scale, and to those in sleep labs, I'm on the DME side. With now the last month plus, with the specific respironic magnetic mask official recall, what have you seen and heard? And once again, the sleep labs, are you guys done anything differently, removed, altered, different discussions you've had?
Yeah, so the question was, for the folks at home, has anybody altered their processes for taking care of a patient that is utilizing a magnetic mask?
Or a new setup as well.
Or a new setup as well. Nationally, I would say it's hit or miss between DMEs and labs. I don't work with labs very much anymore, so I'll take your guys' feedback to our team. DME-wise, people were, at first they put everything on hold. They put all their magnetic mask on hold. Now that other literature has come out in recent light, they seem to be getting back into the magnetic mask, but I'm sure, did everyone have policies in place regarding, internal defibrillators or pacemakers, utilizing those masks with those patients? Was there any crossover there? Did you just try to refrain from using a magnetic mask with those patients? Feedback.
Yeah,
okay.
Penetration studies.
Yeah.
Did that change? Any patient adherence? Change?
Quit using them?
Okay. Now, I thought the recall was for Respironic, about a mask only. Is that correct? Correct.
And it was for only certain restaurants.
Every mask
Correct.
has a magnetic.
Magnet.
But the ResMed magnets, is there something special about ResMed?
I'm on camera. This is the worst part.
So yeah, there's a difference between the magnetic strengths. Okay.
Thank you.
That's what they're telling us. There's a difference. The studies they did, there's a difference. Okay.
Yeah.
But Fisher Paykel doesn't have magnets. There you go. Selfless plug. There you go. Never has. Never will. But you don't have
Hey, you do.
I don't work for Fisher Paykel.
Oh, I thought you did. Oh, so did I. So FNP should have some sort of sample plan, I thought.
F&P throws out samples left and right. What you have to do with the big article today?
Anything else? Cool. Thank you all.